Hi everyone, welcome to another Foresight Hivemind. This week we're going to do deep dives into the topics that we've already been diving deeper in over the last 3 weeks, specifically in the most promising ones. One of them, of course, that is very close to the heart of many people at Foresight, but that is also just a tremendously promising opportunity right now due to COVID-19, is aging and also specifically health. Currently, I think there is this kind of like very fortunate spotlight on many of the things that we could be doing to improve our health and extend our health for much longer. So I'm really, really happy to be talking about this topic today with a fantastic panel. We have Reason from Fight Aging and from Repair Biotechnologies. And we have Michael Vassar on from Nanotronics and Erica Frank joining here as an MD, even though we have already had the pleasure of having her on previously to talk about Next Gen U, which is an effort that she launched right now to extend accessible online education for all. So I'm really, really happy to have those three folks on. Maybe we can charm Jim O'Neill into saying a few words too, who's currently here on co-host. But for now, I'm super, super interested in what we come up with last week, basically where we left it off. And I'm going to post a few links here in the chat that may be helpful. But we left it off last week, basically thinking about ways in which we could just make the connection between aging and your risk factors of COVID very clear. So you know that there's a much stronger case to be made right now to actually be funding that research much more going forward. In the wake of people trying to prevent future pandemics from happening. So specifically things that I'm hoping we can tackle, and it's quite a long laundry list, so who knows if we'll get there, are how can we do better in the next crisis, and specifically around topics of aging. So from one, what is the relationship of aging to COVID-19? Then second, are there specific anti-aging treatments that could be fast-tracked as a COVID-19 response or prophylaxis? And then can we kind of potentially preempt possible concerns of policymakers by focusing on positive effects on one's individual health and generally the economy, if those pathways that we come up with are explored, and if the risks and what are the risks if we continue to kind of like squander and postpone effective action on aging? Why is this really a moral imperative at this point? And how can we kind of like how can we make the urgency of funding aging research much clearer? So I'm super, super happy to be joined by this fantastic panel today, and I can't wait for kind of like doing a few deep dives in all of those topics. But for now, I would really love to have Reason kick us off with talking about the relationship of aging and COVID-19 to pick people up from where we left it off at the previous salon on this. Thank you so much, Reason.
Happy to talk.
Yes, awesome. Welcome.
Getting me to stop is usually the problem. So
okay, that's fine.
I think at the high level, the descriptive terms for the failure of the immune system are immunosenescence and inflammaging. And these are slightly overlapping, but are distinct enough to be thought of separately. Immunosenescence at the high level is just failure. Your immune system stops working properly. Inflammaging, on the other hand, is that your immune system is turning its wheels constantly. It fails to resolve the inflammation that accompanies its activities. So you're constantly in a low grade sort of, your immune system is overactive, and that disrupts an awful lot of stuff that goes on in your system, everything from tissue maintenance through to the effectiveness of the immune system itself. An overlapping set of causes cause these things. But when you're looking at why all infectious disease and a whole bunch of other things are worse with aging, it's some combination of these two things. One, that your immune system is just not doing its job properly. And two, that you're in this state of inflammation. You're primed. You're already 30% down the path to 100% inflammation and death. And COVID-19 is particularly obnoxious in that sense, on the grounds that the way it really kills people is not like influenza. It does its own thing where it goes off and spurs a cytokine storm. because of the way there was a very recent publication that looks at how it differs from similar viruses in that most of these viruses are trying to shut down some of the immune system's coordination. And this one doesn't. It only shuts down half of it and leaves the other half, which is the half that says help, help, send reinforcements and sends out inflammatory messaging everywhere. It doesn't shut down that half, which is kind of why it has this characteristic of once you have too much of it, you get these inflammatory storms that kill the person. Anyway, so the causes of all of this are important because if you're going to talk about meaningful therapy has to address a cause. You can't just tinker with the end state of metabolism or the end state of things and hope that you're going to get more than a marginal gain. And I hope that medicine of the last 50 years has demonstrated that. So the causes of immune decline are fairly well understood. The primary one for early dysfunction is involution of the thymus. By early, I mean 50 to 70, let's say, 50 to 80, 50 to 70. So your thymus is over your heart, under your rib cage, really inconvenient location. It's a little organ in which your adaptive immune system cells turn from their immature state to their mature state. They get educated in there. And this organ is mostly gone by the time you're 50. And you're coasting on fumes effectively because now you don't have a supply of new cells across the whole of your life. The number of T cells you have is about the same, except they're gradually after age sort of 40, 50 becoming crappier and crappier because they don't get reinforced with new cells. So obviously there's a bunch of us, small bunch of us, 3-4 groups trying seriously to reverse that in one way or another. Now, the other thing, which is more pertinent to late dysfunction, let's say 70 and on, though certainly at 60 you're not happy, is the dysfunction of your hematopoietic system. And the hematopoietic system sits in your bone marrow. It's a collection of stem cells and progenitor cells and their support systems that produce all immune cells, including the ones that go to the thymus to be matured, but they produce the innate immune cells fairly directly. So these suffer all sorts of interesting dysfunction, a lot of which appears to be connected to inflammation, such as their myeloid skew, which is they produce too many myeloid cells and not enough lymphoid cells. And in general, loss of function. There was a rather great article from some infinite number of years ago where they took a sample from the bone marrow of a very old lady, and they went to count the number of functional hematopoietic cells that were sitting in the bone marrow in that sample. And they found literally two cells that worked in that sample. So at a certain point, it doesn't matter what your thymus is doing. You're just not generating the raw cells that will then do the job. So interestingly, there's a lot of crosstalk between hematopoiesis, the generation of cells, and the thymus. The cells that come from the bone marrow and go to the thymus are secreting KGF. And KGF, if you dump it into a thymus, causes the thymus to grow. And the thymus itself, there is evidence for its function to actually influence hematopoiesis, though the mechanisms there are not very well understood. So it would be hoped that anything that works on one of these would have a sort of beneficial influence on the other to some degree. So the last thing in that list of reasons for things being terrible in the aged immune system is that your aged immune system is just mostly junk cells. It's cells like age-associated B cells, which are just pathological and useless. There's lots of little pathological subpopulations of T cells that have gone awry in characteristic ways and sit into tissue A or tissue B and cause inflammation or cause disruptions to things. There's outright senescent immune cells, of which there are lots, and they cause probably more harm than the good they do by surviving for longer by being senescent, because they're kicking out inflammatory signals, and they are a sizable cause of inflammation in general. There was just a paper published earlier this week in which they talked about a subset of senescent T cells that sit in fat tissue. And of course, obese people have a lot of these, which is why obese people are not so well off. Inflammation is the mediation between too much fat tissue and all the horrible things that happen as a result of having too much fat tissue. It's a major factor. And lastly, in that list, a clonal expansion of memory T cells connected to persistent infections like cytomegalovirus for most people, or herpes type viruses of other sorts for those unfortunate enough to have them. Effectively, because your body cannot clear these things, it just keeps devoting more and more cells to remembering that these things exist. And eventually this becomes such a huge population of cells that there's no room left for other more effective cells, and you're not getting reinforcements anyway. So more and more of your immune system becomes uselessly specialized to these persistent infections that you can't clear, which just degrades your population that's capable of doing new things. So that, in a summary, is that. And I think I already said COVID-19, severe immune storms. It's very analogous to why sepsis is an age-related condition, because old people, A, they can't resist the virus in the first place because their immune system sucks. And B, once you have too much virus, if you're already inflamed, then it doesn't take that much more to tip you over the edge into a severe cytokine storm that will kill you, in effect. And that's what sepsis is in old people. And that's what COVID-19 does in the lungs. So I think that is a starting.
All right. Yeah, that's definitely quite the laundry list there. I think Creon had an immediate question to your introduction of this. Creon, I'll unmute you because it's directly relevant. And Michael and Erica, if you want to fill anything in, and then you're welcome to do so afterwards. Just put the hand up, and then I'll know that you want to contribute.
Okay, thanks, Reason. That was great to hear, get refreshed on that stuff. My question was pretty simple, and maybe you already answered it, which is you had mentioned immunosenescence and inflammaging as two avenues, but overlapping to understand this stuff. Isn't inflammaging one of the big drivers of immunosenescence?
There's this is one of those things where there's a big stack of causes and consequences, and people are happily making their careers arguing over what came first, chicken and the egg. There's a crosstalk between the two of them, the mechanisms involved, and you'll read papers which says A causes B and papers in which B causes A, and likely they both contribute to the other. And until you can get rid of one of them, you can't tell which of those things is the bigger contribution to the end process. It's sort of I like to think of many of these sort of buckets of stuff as just, it's the top end of an expanding tree or a web of interlinked things, and the research community is usually surprisingly fuzzy on which of the things are important, more important or less important. It's easy, quote unquote, to catalog, less easy to pick out which things are important.
Right. So if I may follow up just for a quick moment in another question. So I understand what you're saying, that it's a feedback, inflammaging probably helps cause immunosenescence, and immunosenescence then feeds back and makes inflammaging work. However, there are other things that cause inflammation that are, environmental factors and dietary factors and things like that. And to a large extent, it should be possible, I would think, for us to decrease a lot of those inflammatory factors anyway, we should be able to decrease inflammation without solving the entire problem, at least decrease it partially through, for instance, not exposing ourselves to pollution and not eating too much junk food and all these things.
Those senolytics should beat out almost everything you can do other than, reducing exposure to infectious disease, and that's a relative thing. I mean, the level of exposure to infectious disease we have in the first world is pretty low already.
All right, thank you.
Current headlines accepted.
Yeah, current headlines accepted. A current pandemic accepted. Do Michael or Erica want to fill anything in? No? Okay. I strongly encourage you to check out those two slides. They're on the SENS website. Can you see my shared screen? Yeah, right? Yeah. It's very small. Yeah, I know. I just want you to take a look at those two graphs for whom it isn't crystal clear yet. I love, first you have current case fatality rate by age group, and then you have an age flattened curve. And I think this one is hard to spot, but I think it's a really interesting one to look at. And age flattened, I think, is also, I think a really nice meme to spread. So that's just one. Second one here, you have comorbidity by age group for COVID-19. And, again, here, this number is just, I think, a little bit concerning, but also I think, once you see it, the relationship is just really crystal clear. So I encourage everyone who still has doubts to check out the Sense, kind of like the Sense little primer on this. It's really, really good and really easy to understand. And I'm going to share the link to that here. Thank you so much, Reason. Erica.
Yeah, I do actually have something to say about that first graph, if you could, if you bring it back up for a moment. So it's really to both points, Chris, and to say what's kind of interesting is the caption below it talks about aging. And the actual data are presented, as would be customary, as age in years, right? And so part of what I think is interesting to dissect here is the difference between chronological age and agedness, right? And so I think it's pretty well portrayed in this particular graph with its legend, the way that we always conflate those. But I think the point that Cree is making is that it's critical to, both of y'all were making that, is that it's critical to extricate those two pieces. So just wanted to point that out in this illustration.
Okay, yeah, no, fair enough. Thanks for the pointer. Okay, so maybe let's see, I'm going to stop sharing. If I don't know if anyone else has anything to contribute on the panelists.
Right. Let's say
yes.
insofar as we have symptomatic treatments for the symptoms of aging, it seems like a relatively short-term thing that we can do that makes use of COVID is explore the use of symptomatic treatments, anti-inflammatories, anti-blood sugar medicines, as a preventative for COVID mortality. It doesn't seem like it should be very hard to put a group of 100 non-pre-diabetic or 1,000 non-pre-diabetic septuagenarians on metformin and 100 non-pre-diabetic septuagenarians on a high-power anti-inflammatory cocktail, and find out whether these effects are preventative against aging. There are potentially doctors can do this because they can just make things off-label, but then they can just decide that they believe in a thing. There are weird issues that have to do with preventative medicine, where we seem to treat vaccines as maybe almost the only type of preventative medicine that has a special category in approval, and which is kind of a problem. And there seems to be a pathology where people don't understand that everything in life is an experiment, and we have this creepy idea of medical experimentation as bad, rather than doctors not claiming to know everything is good. But the doctors are totally able to recommend these things now. So I think Reason is raising his hand, please. Reason?
I was just, the hand does what the hand does. I was just posting a link to the chat there to say that, people are definitely already publishing papers, never mind talking on let's do antiviral. Let's do antiviral stuff, anti-inflammatory stuff for COVID. There's a whole bunch of papers and commentaries here to look at in terms of people saying, let's go try, inflammation suppression approaches for this. And I think
quite preemptive, preventative anti-inflammatory.
Yeah. So to your point specifically on metformin, Michael, that trial actually is being done. There's a huge natural history cohort of people who have chosen, who are pre-diabetic, to take metformin prophylactically. And while they have some different characteristics undoubtedly at baseline versus others, those data, I agree, would indeed be useful to look at their attack rates, for example, or their incapacity as a result.
Senolytics are probably more interesting from an effect size point of view, but I suspect a harder sell for the IRBs of this world.
Yeah, Erica, what you just said about metformin trials, it's true that there are a lot of people taking metformin in the hope that it reverses aging, but they're not all having their data collected in a central place. The TAME trial was approved by FDA in 2015, but it hasn't been conducted. So there's low-hanging fruit if someone wants to put $40 million towards a probably extremely interesting study.
So why has if the approval was so long ago, why hasn't it happened yet?
It hasn't been funded. So metformin's a generic drug. Yeah, go ahead.
Sorry. One way to sidestep that is there's a site called beat19.org that is prospectively tracking folks where you put in the meds that you're on, and there's a daily check-in about your symptoms. So if one could steer metformin takers to such a site, you wouldn't need a $40 million grant, right?
Yeah, that's a good point. I mean, not everyone would be as persuaded by something kind of informal, but it would be much better than nothing because people are already day to day trying to make this decision. Is it worth the expense and the argument with my doctor to take metformin? And so the more data there is, even if it's not perfect, the better, absolutely.
So just to be clear, that's an IRB approved. I'm just putting the site into the chat. It's an IRB approved site. If anyone's interested in pushing them toward that, I'm happy to make that link.
Thank you. That's helpful.
Yeah. So I guess I'm somewhere in Germany we say standing on the pipe. Like $40 million is not like an insane amount, and it's been quite a while, since apparently that approval went through. What happened there?
Well, the trial was proposed to FDA in 2015, and it was approved, which was considered a big breakthrough because it was the first time that anyone could think of that FDA had approved a trial for something sort of like aging. Now, it was a very specific technical definition of a basket of markers that were called aging, and of course, not everyone would agree with it, but it's still a conceptual breakthrough. But metformin is a generic drug, so no one stands to profit off of more people taking it or any kind of approval. So while it was kind of a conceptual milestone, a really good trial, the kind of trial that was approved, would have to look at at least 1,000 people over a couple of years, and so it's pretty expensive. So people have been trying to raise money for it, probably on a nonprofit basis. And it would be great if that trial were conducted.
The important work was done here, that the trial does not actually have to run in order to have achieved the breakthrough. The breakthrough was Nir Barzilai browbeating the FDA into agreeing to his proposed definition of aging. Now, if somebody else comes along with a therapy that actually has a meaningful effect, which, apologies to everybody else, but metformin does not. It is not something we should be spending $40 million on. If somebody else comes along with, let's say, a serious senolytic that actually has real, interesting, severe effects on aging, really good, something worth talking about, and then they come in and say, we're going to use the same trial thing that just got approved, this metformin thing. I think that would happen, and it would prove that Nir Barzilai did his job and everything worked. I don't think we need to throw enormous amounts of money at metformin to finish that job up. Though, of course, feel free.
What do you propose then, Reason?
I propose we continue to focus on building things that work, and then actually putting them into trials aggressively.
What would you propose for the FDA now to qualify under that newly unlocked
I think senolytics are the only thing on the table that's really worth talking about at this stage of development, until such time as somebody gets the, there are 2 or 3 areas of development that are interesting once they have more data, one of which is epigenetic reprogramming, one of which would be mitochondrial repair. If somebody comes up with a really good way of doing that, none of them are quite baked yet. And everything else I don't think is ready for that. You need something which demonstrably is really, really great in animal studies, unarguably great. And at the moment, the only thing that has that sort of backing is senolytics. Give it another few years, maybe epigenetic reprogramming will be there as well, but definitely only senolytics right now.
So does anyone remember Raphael Schmigalski's mitochondrial repair stuff from about 15 years ago? I remember he used to speak alongside Aubrey de Grey at transhumanist events. And I haven't heard anything about it for more than a decade, but does anyone else have news on that one?
What was the name?
Raphael Schmigalski used to do mitochondrial repair stuff. He used to be one of these more promising lines, I thought, of research back in the early SENS days.
Not something I'm familiar with, which probably indicates that it didn't replicate well.
Well, it could, or it could mean it was never followed up on by anyone or developed by anything. Like most things that have promise don't ever get investigated.
Yeah, send me an email with the, or post it in the chat here. That would be useful.
Hey, Reason, don't you think it would be interesting for someone to do a large controlled replication of Greg Fay's thymus trial?
Yes, I hope somebody gives Greg a bunch of money so that Greg can do a large controlled replication of his trial, because if he does it, then there will be a clinic at the end of that story. And
right.
any of us interested in that line of things can go do it. And while the door is kind of closed on the 2 alternatives to his system, much as I hate the idea of sticking growth hormone into a person, but there's definitely the argument that a year of growth hormone is probably, if it regrows your thymus, is probably a devil's bargain worth taking, based on the data they produced. But yes, that definitely, it would be interesting to do more there and see where that goes. The other 2 alternatives, by the way, are sex steroid ablation, which A, doesn't work in women, so far as we know, or at least there's no data for that. And B, there's no way to do it in a way that's going to reliably give you back your sex steroids after it's done. The third is KGF, keratinocyte growth factor, which regrows the thymus really, really well if you inject it in there and get it in there in large enough amounts, but it's not approved for human use in anything more than like a 10th or a 20th of the amount needed, and it failed a human trial at those levels. So currently Greg's work is the only game in town if you want to do something in the next few years.
Creon, you mentioned Greg's current work. I just posted a link to Zina presenting on her work with Greg on reversing epigenetic aging. And like you mentioned, okay, Creon, I'm just going to unmute you so you can speak for yourself.
Thanks, Allison. I just wanted to mention that he is doing a follow-up. It's much bigger. The original was called TRIM. This one's called TRIM-X. They're expanding it to women and different races and the larger numbers. And I don't know, maybe additional permutations on the treatment.
All right. Okay. Thank you. I'll mute you again. Okay. So we already talked about a few examples, but maybe are there and those are already always promising. Are there specific examples of either specific pathways for research or even already much further along, almost company ripe ideas for that could be pushed right now and would be really promising in COVID-19 that would tackle some really promising aging treatments. So if we came out with this and said, okay, here's something that is not only a good idea for aging, but that is also a really good idea to push for right now in COVID-19 because it kind of catches both of those flies in one go. What would that be?
Yeah, there's a couple of things that are on my to-do list in the sense of, hey, if I have time sometime in the next decade, I should get somebody to do something about this if I don't do something about it. So Draco is an interesting approach to generic antiviral platform in which you go suicide bomb the cells that have viruses in them, which in theory would not need much adaptation to each new virus. And there are a bunch of people trying to do something with getting that off the launch onto a launch pad somewhere, and for whatever people-related reasons, that research kind of died on the vine. But somebody should go rescue it. Once this bear market is done and everybody's back to believing in infinite money for everything, then somebody should go rescue Draco. Just take it out of the hands of whoever is sitting on it and being silly, and just go develop it. It's really great. Another line of work, of course, is all the thymic rejuvenation stuff, which has been talked about ad nauseum, and I think that is interesting. John Lewis's sort of growing collective of companies around Entos Pharmaceuticals. They're also Ocean and Oncosenics and a bunch of other things, and now they have an Aegis company, which is basically their antiviral thing that they had going, which is now quickly being polished up and put into production and is raising money right now. And they have some sort of interesting antiviral approach of their lipid nanoparticle platform, which is along the lines, I think, of Draco, if I read correctly, but sort of slightly similar. And there's probably a couple of others out there we're talking about in the presently around or could be rescued bucket that are sort of attacking viruses specifically, but would also generally be useful.
Okay, any other Trojan horses? Michael, Erica?
I don't think that I would have a strong opinion about this. I haven't been tracking trials of things. Like, I would have guessed metformin was still a promising thing. Reason seems to know more. It may be that he is saying that it's not worth it because there are better low-hanging fruit in the senolytic space.
Yes.
But the question of whether something whether there are better things isn't the same as whether there are things that work that are somewhat good. And I guess I have moved a long, long, long way in the last 20 years from asking what would be the best thing to do if we were all behaving reasonably, towards asking, is there anything useful that anyone can do that will not get prevented and will not get lied about in a way where the lies outcompete the truth? And it seems like metformin, my take on metformin has been that it's net positive in expectation for most people, possibly for all people who don't have actively low blood sugar by American standards. And that with a reasonable statistical size sample, you ought to be able to see results pretty easily. And since prediabetes seems to be such a huge risk factor for COVID, it seems like you might see an even bigger effect with that than you see with aging. And that would be a great way to get more people using it prophylactically. But if the question is that this has been tried and it turns out not to be viable, even for a weak effect, then my information is just not up to date enough.
I rather fear that metformin is in the same bucket as aspirin. And you can look at the last 20 years of aspirin work and see the next 20 years of metformin work, in advance. And you will have this situation where it's just not a large enough effect size to care about, bluntly. And the small effect sizes tend to suck in the research community into spending an enormous amount of time and effort batting back and forth as to which subpopulations of people have positive versus negative effects.
So I agree. I believe that small effect sizes will produce pathologies within the medical system, but I also believe that large effect sizes will be flat out banned within the medical system. As far as I can tell, there don't need to be reasons to think that the large effect size has bad side effects. People will declare the research to be fraudulent or not relevant or not scientific or not credible simply because it shows a large effect size, in my observations.
Well, on the other hand, we haven't seen any large effect sizes yet.
We haven't seen them on aging, but we see large effect sizes on cancer all the time. And we see active investigation of chemotherapeutic agents with small effect sizes all the time.
I might disagree with that, but we can disagree about that. That's okay.
Anyone else would like to chime in?
Yeah, I'll chime in. So Reason talked earlier about immunosenescence. Several people did. So if you're asking about research that's underway that could help, SENS Research Foundation is doing research to figure out how to rejuvenate NK cells in aging people. They're actually using my blood as well as those of some other volunteers. So we're not going to have a solution in the next few months, but if our research goes well, we do hope to come up with a way to rejuvenate NK cells. And that could be very helpful for the next pandemic.
Does anyone have any informed thoughts on the question that I posed a moment ago too? Is there any reason to think that not adopting Michael's perspective of rather despairing of any optimism or hope, that there actually is some literature to
I really strongly disagree that my perspective is despairing of optimism or hope. I specifically said there are large effect size improvements on cancer all the time. Reason said he didn't want to argue with me about that now, but I'm happy to argue strongly for it's actually not very hard to basically eliminate all cancer mortality and all of the other mortality, not literally all, but 90% plus, and that for most of the diseases of aging. It's just not easy to get widespread distribution of approaches to doing this through the population.
Fair enough. I was really kind of just using it as a springboard to ask the question about whether anyone thought that there was any merit writ big to this notion of optimism itself as being an intervention that actually has measurable, reproducible consequences on morbidity and mortality. I reread this article yesterday from the Times that had some encouraging literature. It is not something anyone's done an RCT on, but I wanted to know if this cohort thought that there was anything to it or not. Because it sure is the kind of thing that a lot of patients trade on. No? Okay, it will remain yet another mysterious variable for the moment. Thanks.
Yeah, I'm optimistic about the fact that being optimistic is a generally good strategy to pursue in life. Okay, so let's see. Well, we've already covered like a few, or like at least we've thrown out a few suggestions here for what people could follow up on if they were trying to put their money where their mouth is in terms of extending human health. I would love to see kind of, on a more let's simulate an example in which we would actually be talking to policymakers that would actually be willing to potentially spend some money wisely. Could you kind of like come up with a few concerns of what they may have about spending it on the treatments that you're proposing, and why ought they not be concerned about? Like how could society look like if we actually got our act together and started spending on this now over the next, let's say, 10, 15 years, and what are the risks if we don't do it?
I think getting policymakers to do the right thing is a fool's errand, personally. I mean, one gets more cynical about...
Let's aim lower. Let's go for investors then. What are...
even worse. Better one. But the policymakers, I think one has to look back at like things such as the nanotechnology debacle of 10, 15 years ago and see that even once you get people interested, the money doesn't tend to go to the right place. I think the best thing to do is build things that work. And then, society will come around to deal with them.
Anyone want to chime in? No? I'm specifically thinking, okay, let's, what are...
important. I think it's important if nobody can even imagine what it would look like for policymakers to not be malevolent. And if no one can even imagine what it would look like for investors to want to make money, and I don't believe anyone here can even imagine what it would look like for investors to want to make money, like they would have invested in Tesla a lot more a lot earlier. Like seriously, literally, then it seems like we need to like figure out how to morally emancipate ourselves from top policymakers and investors who we believe are trying to kill us. And like, I think that that's a not super hard medical problem. I think it's a neurotech problem, and that we have the understanding of neuroanatomy to like reprogram our brains so that our thoughts aren't constrained by loyalties to things that have betrayed us.
And but who would invest in that, Michael? How would you get anyone to invest in those new technologies in the first place?
The National Science Foundation. The National Science Foundation has done so. Like there's a great, fairly well-funded project at Stanford by the NSF using transcranial magnetic stimulation to amplify hypnotic susceptibility, which has absurdly obvious, like, unfortunate implications. But like, you know, if black magic is criminalized, only criminals will have black magic.
I think I might like to use that one as an example of my earlier point that the money doesn't tend to go to good places.
Yes, but this is a useful place for us if we want to actually make use of our own minds.
All right, maybe a question to the panelists is like, can you imagine, can you give us an example of the last time where you thought that actually spending was dedicated to like an to a place that turned out to be incredibly beneficial. Let's take aging as one example, and that could be either a policy, that could be either government money or it could be private investments. Like what's kind of like a grim of hope? Where can we point to that was like, okay, yeah, they totally got it, and that was a great example. We should be doing more investments like that.
Well, obviously, anything that went to Methuselah Foundation and SENS Research Foundation had like a much greater return on investment than pretty much anything the NIH was doing at the same point in time.
Would you be guessing like more like 1,000x or more like 100,000x on that?
Hard to say. I mean, like if we want to say the NIA was sitting there doing, whatever the hell it was doing the last 20 years, funding that part of basic research, which is really boring and doesn't really achieve a great deal. I think the better comparison would be the Ellison Medical Foundation versus SENS Research Foundation, because the Ellison Medical Foundation was basically a private version of the NIA. And to a first approximation, can we find somebody who knows of anything useful that came out of that? Versus, hey, we turned the whole for some definition of the SENS Research Foundation, its network, turned the whole research community around on the matter of aging in a matter of 12 years or so. Pretty good.
Yeah, I'm very, very, very impressed by how useful it was that Aubrey had a lot of inherited money and was able to fund his own research and therefore didn't have to compromise at all on research quality that he was promoting. Because as far as I can tell, there's just, whenever people think that they are reducing the effectiveness of their research by a factor of 2 in order to make it an order of magnitude more fundable, they're actually reducing its effectiveness by 2 orders of magnitude to make it an order of magnitude more fundable. And, radical inequality of initial distributions of resources is actually a pretty good solution to that sort of problem.
So I must admit to a considerable fondness of NIH trials like the Women's Health Initiative. And I also, I recognize that fondness may be clouded by familiarity, but, that was a good example of where there was a drug that was in wide use in the population, hormone replacement therapy, where we as a cohort of physicians specializing in preventive medicine and also in treatment had made all sorts of assumptions about its merits and usefulness and had prescribed it liberally as a result. And then we did a huge national trial and found that it had all sorts of important side effects and didn't have the primary effects we were hoping for. And its use mainly evaporated. That, to me is how I think it's supposed to work. But please feel free to spritz on that parade if you think I'm mistaken in my appreciation of it.
So my experience with FDA regulators has been that they are smart, honest, thoughtful people who are trying to implement reasonable rules as honestly as they possibly can, given the constraints of bureaucratic dysfunction, and that they're facing less than typical bureaucratic dysfunction and legitimately feel that this is very unfair, but also that the amounts of bureaucratic dysfunction that they face are sufficient, that they have to compromise the scientific integrity of what they're doing enough, that in aggregate, what they're doing is worse than it would be if there was no FDA.
I would agree more or less with that. I think my experience one of our programs at Repair Biotechnologies is explicitly something that was rejected by the cardiovascular arm of the NIH for further funding because it was not the done thing. It was too ambitious. It was too different. It was not the existing, portfolio of things you're allowed to do to treat cardiovascular disease. And frankly, it's going pretty well for us. In a system in which the only things you're allowed to do are things where you can basically prove that it already works, which is essentially how most public research funding works in this part of the world. The only people who make progress are the heretics around the edge, and progress is necessarily not very well funded.
Yeah, I'd like to comment on what Michael and Reason have said about bureaucracy, specifically NIH. So NIH is extremely siloed, even for a bureaucracy. It has more than 25 different institutes inside it, and they each get their own budgets and mandates from Congress. And that has led to an extremely siloed, hyper-specialized construction to all of science, unfortunately, or all of biology, which is the complete opposite of the way that we ought to be thinking about chronic disease and diseases of aging, which is holistically, which is that aging is the accumulation of damage and its pathologies are the diseases of aging. And it really ought to be studied that way. Even the NIA, the National Institute of Aging, that you would think from its name is taking a holistic view of this, is not. Its budget is just as hyper-specialized as the rest. So just to take an example, Alzheimer's and Parkinson's, both are consequences of aging, pathologies of aging, both involve dementia. They have some interesting differences, of course, but they ought to be significantly studied together and specifically studied much more upstream. And they're in completely different institutes in NIH, even though they're both essentially brain disorders. So while I get that it feels futile to try to talk to policymakers, even the very bureaucratic ones are likely to sort of admit at some point, all this hyper-specialization does have a downside. Yeah, we are really siloed here. It's Congress's fault. It would be more productive to take a more holistic approach. And I'd like to add one other thing about NIH, which is by its very existence, it probably is limiting the amount of donations that SENS Research Foundation and our peers are getting, because to the people that are not obsessed with aging, it's easy for them to think, oh, there's already a multi-billion-dollar institute studying all this stuff. So science is probably advancing as rapidly as is possible.
Yeah, absolutely. That's just enormously important. It just everything needs to be in the frame of that. It's just if you're not helping efficiently, you're hurting.
Yeah, absolutely. Sorry for the rant, but I wanted to throw that there.
Jim, I would love to know, let's say I'm in the FDA, I'm realizing, oh my God, super siloed here. What do I do?
Well, FDA is not as siloed as NIH. FDA's problem is that it's mandated by Congress to take a guilty until proven innocent approach to innovation. That was a terrible decision that a bunch of members of Congress made in 1962. And the best thing someone at FDA could do would be to try to persuade Congress to change their minds. But frankly, we probably have more access to persuasive techniques than people inside the bureaucracy. So it's really on us.
Right. I think if you look at the history of people turning up at the door of the FDA with things that really actually work and really actually cure the indication that they're going for, the ways are found to push the thing through the system at a faster pace and something more closely approximating a reasonable, they're still pretty obnoxious, a reasonable expense. I mean, if you turn up the FDA with a cure for a specific, illness which has no current good treatment, you'll do fairly well usually if you have the right connections.
What's a good example?
Boy, I have one at the tip of my tongue, and I can't give you one off the top of my head, but this has definitely happened several times in the last decade, where a really, really good therapy for a rare condition turned up, and it's a couple of years getting it through accelerated phase 2 trials, and then it's out there.
Okay, and Jim, you said FDA. It's hard to change it from within, and maybe we even have more bargaining power there. So, what would you recommend folks on this call to do?
I would say the highest effect thing you can do, the thing with the highest effect size, is to persuade people to devote more resources into critical life extension research. SENS Research Foundation, Buck Institute, Methuselah Foundation, many others, all of us. The biggest rate limiting factor is the amount of resources that we can pour into it. So that's affecting the speed with which the solutions we're working on are going to reach patients. That's probably the highest leverage. The second highest leverage would be to try to persuade policymakers to just get out of the way.
So on the comments, Todd Turpin just shared, reminded me of orphan drug stuff, which is certainly one of the best ways to get the policymakers out of the way. There are a lot of programs whereby drugs can be developed for a rare disease in a way that couldn't be economically viable, but which doesn't have a lot of regulatory burden. And then in potential, that drug's available, and if doctors could be convinced to distribute it off-label, if you have reason to think it'll be helpful for something common relating to aging, that's a pathway.
Which is what everybody tries to do if they happen to have a convenient rare disease that their therapy will work for. It's always going to be. It's not as good as it used to be financially, to the point where it's a no-brainer decision. You do actually have to at least run the numbers a little bit nowadays. But it's still the case that, if there's rare conditions out there, go do rare conditions and structure your therapy such that off-label is possible.
I mean, I don't know if there's a good searchable database for rare conditions. That seems like a good tech project that someone could make pretty easily.
There's a whole website, Rare Diseases, that specializes in that.
So, and it's organized so that you could look for a way to justify a molecular action on a particular pathway as treatment for a rare disease?
Well, generally what happens is, there are so many horrible mutations. So whenever you're dealing with something that affects a protein from a specific gene, you go look at all the genes in the pathway that's involved in and say, are any of these conditions associated with mutations of these genes something we could deal with? And sometimes the answer is yes, and sometimes the answer is no. I mean, for us, we target FOXM1, so obviously it would be great if there was a rare condition associated with dysfunction of FOXM1, and there is. Unfortunately, it's so rare that it would take us 20 years to run a trial. Sometimes you can have too much of a good thing.
All right, we're now at 1 p.m. So I just want to, in case anyone needs to hop off, I want to close it out officially. you're welcome to stay on, obviously, but I just want to say now officially thank you so much on my end for having come on.